Okay, well, hello everyone, and welcome to another session of the Virtual Global Spine Conference. I'd like to welcome everybody who is with us today. We are happy to have an outstanding colleague and fellow spine neurosurgeon, Dr. Javier Quillo-Olvera, who is visiting us virtually, hopefully visiting us in person, but at least today he's visiting us virtually on Virtual Spine to share with us his experience with spinal endoscopy cases. Javier is a graduate from neurosurgical residency training in Mexico City, followed by several fellowships, one back home in Mexico, and then after that, a fellowship dedicated to endoscopy in Seoul, South Korea. And he is back in his in a hometown close to the capital, where he focuses exclusively on spine, with an emphasis on less invasive techniques as well as endoscopy. So Javier, thank you so much for joining us. We're looking forward to seeing your cases, and of course, as we always do, challenging you and with difficult questions, but that's what makes this fun and interactive. So welcome, and you can go ahead and get started.
Hey, thank you so much, Ali. Thank you for having me here today. It's an honor to share my thoughts about spinal endoscopy in a case-based series. Let me share my screen. Can you see my screen right now?
Yes, we can. It's perfect.
Perfect. Let's go start. So we have basic learning objectives regarding this talk. For example, explore the role of spinal endoscopy in different degenerative pathologies of the spine through clinical cases, demonstration, identify different endoscopic approaches to resolve spinal pathology presented in these cases, and familiarize with different technique that is called unilateral biportal endoscopy, which is another water-based endoscopic procedure. So today we're going to talk about only for water-based endoscopic procedures. We have two major categorizes in this feature. For example, uniportal endoscopic surgery and biportal endoscopic surgery. The main advantages regarding of endoscopic approaches are invasiveness compared with open surgery, compared with tubular surgery, similar, but the major advantage of endoscopic surgery compared with other minimal invasive techniques, I believe, is visualization of the surgical target. This is a common view after ULBD procedure with endoscope. You can see all the neural structures after decompression very well. And during the decompression, you can avoid damage of these neural structures because of this visualization, which is gained by continuous saline solution irrigation during your procedure. So let's go to start with the case one. Case one is about transforaminal endoscopic lumbar discectomy without foraminoplasty. It's about a 56-year-old male with pain radiated down his left leg, passing through the posterior surface of the thigh, popliteal area, and calf. Past 9, 3 months on evolution with no lower back pain. The patient underwent 2 times foraminal blocks. The first one improved the pain for at least 6 weeks, but the second one did not work. The patient underwent physical therapy for at least 4 weeks, but was unsuccessful. Clinical examination demonstrated decrease of the strength in the dorsiflexion of the left ankle, significant paresthesias on the lateral aspect of the calf, and dorsal surface of the left foot, with the left Achillean reflex decreased. Preoperative lumbar X-rays didn't show instability. Here are the images of MRI. The preparative MRI shows a central-lateral discerniation with a stenosis of the left lateral recess at L4, L5 with a subligamentarius discerniation. You can observe here in the L4, L5 and the sagittal view of the MRI. So we conclude with this diagnosis: the left-sided L5 compressive radiculopathy with a L4, L5 central-lateral extrudated discerniation in the left side. We have options as surgeons: open surgery, microdiscectomy, tubular discectomy, or choose full endoscopic lumbar discectomy. For example, use the interlaminar endoscopic lumbar discectomy. But remember that you have to perform more bone removal to an interlaminar endoscopic discectomy at L4, L5. This case is very suitable for beginners with interest in transforaminal endoscopic approach. I went for transforaminal endoscopic lumbar discectomy. So I planned the surgery like this. You can observe here the foraminal area, and precisely you can see here that the exciting nerve is in the upper part of the foraminal area, and you have this space for doctor working cannula and your endoscope and working the disc. Other important feature is that the highest point of the iliac crest is not above the L5, so you can reach the foramen directly to a transforaminal approach. In this case, I went 11 centimeters lateral of the midline, from the midline, and then I dug my initial needle in a subannular area at L4, L5. I never crossed the mid line of the interpedicular line. And then this is the intraoperative video. I rotate my cannula. Here is the bevel of my working cannula, retracting the epidural space. So I get oriented with this probe. I know where is the epidural space and where is the annulus. So I can see in a half and a half vision the annular defect, and then reach the target without enlargement of the foraminal area. Just a direct approach, but not inside-outside approach or outside-inside, just half and a half to see my target area, which is the annular defect, and then reach the lumbar disc herniation. Sometimes you need your radiofrequency probe to decrease the volume and remove easier the disc herniation. Finally, you can observe the structures. Here's the superior end plate. Here is the inferior end plate. You can see the pulse of the neural elements in the epidural space. This is the subannular area. And when we remove the working cannula, you can see the SIP, the notch of the pedicle, and finalize your procedure. Here's the case 1 postoperative lumbar MRI. You can observe disc herniation in the preparative MRI and enough decompression in a subannular way without touching the facet joints, respecting the facet joint width or approach. Do you have any question for this case or any comment, dear Ali or colleagues?
Yeah. Thank you, Javier. Great first case, and I'll ask you the same question I just put on the chat box for everyone to think about, which is, how often are you doing these transforaminally, and how often are you going interlaminar, or does it really depend on the pathology?
I think it's depending on the pathology. For example, I wanna return to the. You can observe that here the disc herniation is suitable for reach through the foramen, and also the foraminal area is very suitable also to introduce the endoscope to the foramen. So you have to take into account the features of your the anatomical features of your case, and then if you can reach your pathology through these anatomical features, you can choose your approach. The benefits of the transforaminal approach is this approach is the least invasive approach for decompress the ventral epidural space compared with the interlaminar approach. So I choose the approach depending on the location of my target. These techniques, endoscopic techniques, are very target addressed procedures. So they are highly specifically techniques. So this is the way that I choose my approach in this case. Also, there is no there is no compression of the thecal sac. You don't need to get this distortion in the anatomy or another injury than the pathology for when you consider your approach. This is my answer.
Perfect. Thank you so much.
Okay, let's go for the case 2, the transforaminal endoscopic foraminal decompression. This case is very particular. It's about a 68-year-old female with diabetes, hypertension, obesity, but the patient had severe radicular pain in the right leg with 2 patterns identified. The first one is located in the anterior thigh with dysesthesia-like pain, and the second one runs down her leg along the posterolateral surface until the medial aspect of the calf. The patient notes no lower back pain, 4 weeks on evolution. The first pattern appears before the second one. The severity of the pain was 9 in VAS, but improves a little bit with buprenorphine. The patient had intermittent claudication with few steps, and the pain occurs during sitting and walking. So clinical examination demonstrated decrease of the strength in the knee extension of the right side and claudication because of pain in the right leg. This is the preparative MRI. You can observe here at L2, L3, upward downgrade this migration here, obstructing the lateral recess and especially the foraminal area. Here in the axial view of the MRI, the pathology is in the foramen here in the right side at L2, L3. But this was caused of the pain, the dysesthesia-like pain. But the other pattern, the sciatic pain, for example, this is the reason the patient also had foraminal stenosis at L4, L5 in the right side. You can see the foraminal stenosis at the L4, L5 in the axial view, and the bone components of this foraminal stenosis in the preoperative CT scan. So we conclude with L3 and L4 radiculopathy in the right side, with foraminal downgrade, upward migrated discerniation at L2, L3 in the right side, and L4, L5 symptomatic foraminal stenosis. 2 patterns of pain, dysesthesia in the anterior thigh and sciatic pain that runs down in the leg. So we have treatment options also. You can go for the pain with foraminal blocks at L2, L3 and L4, L5. We can perform fusion at L4, L5 because thinking in the degenerative changes for resolve the pathology, but we miss the L2, L3 pathology, or we can go for a direct decompression of the pathology because the pathology is compressive, causing 2 different radiculopathies in the same patient in the same leg. So I went with a full endoscopic transforaminal discectomy at L2, L3, and foraminal decompression and lateral recess decompression at L2, L4, L5 in the right side. It was my first procedures. I land my initial needle in the disc in the upper end plate of L3, only to reach the lateral aspect of the foramen. And here is the intraoperative video of the discectomy at L2, L3. My working cannula is floating. We are not into the foramen. I am outside of the foramen because I am respecting the flavum ligament, the foramen ligament. Here is the disc, and you can see how we remove the disorientation. Here is the foraminal ligament, and upward or above is the supraarticular process. Then we remove the disorientation piece by piece, carefully, until reach, because the foraminal area is too big. We don't need foraminoplasty to reach the pathology because the pathology is too lateral in the foramen. It's a foraminal disorientation. And then we can observe the...
Javier, can I ask you a quick question?
Yeah, please.
Great, thank you. The, you know, when we're doing these, let's say in a traditional fashion, or you know, let's say you're using a tube or a McCullough retractor or whatever it is. Let's say you're doing an open microdiscectomy, and just about when you're either retracting a little bit on the traversing route and you're trying to find the annulus, cutting the annulus, you get a little bit of epidural bleeding, not a lot typically, just a little bit. I'm not seeing any here. Is that because you're just completely outside of the area where the veins are, or did you just crop out the video so we don't see any bleeding? Tell me why it is that visualization is amazing and really perfect. But when do you encounter the epidural bleeding, if at all, and how do you manage that?
Okay, now bleeding occurs in spinal endoscopy, and it's very common. Yes, in my first cases, I had to try different options to improve my visualization regarding bleeding. But when I reached my learning curve, I had a few cases with bleeding because I do that. First, I'm using my hydrostatic pressure in my favor. So it doesn't mean that I started with 100 centimeters of water or 100 centimeters of mercury, millimeters of mercury, but I try to initiate my surgery with 30 millimeters of mercury in the pressure. The second thing is I planning my surgery, and I address my planning my trajectory and address my initial needle to a bone landmark. The bone is our friend. That is a advice from Tony Young and Professor Koichi Sairo from Japan. The bone is our friend, so I'm landing in the friend, so I can damage the soft tissue. When I go with the endoscope and the working cannula, I respect, when I rotate the working cannula, I respect tissue, and I put my bevel above. And then I always moving my working cannula to avoid the tissue that is bleeding. So when I have bleeding, I increase my pressure and I see the target of the source of the bleeding, and I coagulate the bleeding. We have other options. For example, we can use hemostatics like flow seal. We can introduce solutions with adrenaline. We can stop the surgery and increase the pressure, wait for 1 minute or 30 seconds, and then after a coagulation, we can go again for the or procedure. These are the options to treat the acute bleeding during our surgery.
Thank you. Thank you so much for that.
Okay, I will show you how I saw in this case the traversing nerve. You look at the vessels, the epidural vessels. So if you go with the working cannula and with the bevel, you can damage that vessels and you can cause a bleeding. So here in depth, you can observe the traversing nerve, and the nerve is covered by the flavum ligament. You can see the bleeding, but I am very careful coagulating the vessels. Here's L2. Here is the exiting nerve. As you can see, I never touch, I never have had contact with L2 exiting nerve, because L2 is covered by ligament, by the flavum ligament, the foraminal ligament. And after decompression, the patient relieves the symptoms, the dysesthetic symptoms. Like here is the postoperative MRI. You can see the discernation in preparative and postoperative. I only remove the migration. Foraminal area is open, and but this patient has two targets. The next target is the foraminal stenosis. So the decompression of the foramen through a transforaminal endoscopic approach is different. In the transforaminal endoscopic discectomy, you have to reach and landing in the or working in the Kembin's area. But when you want to decompress the foramen, you have to land it with your endoscope, with your working cannula in the lateral surface of the SIP. So here is an example. This is the working cannula docked in the lateral surface of the SIP to start in the decompression. In this patient, I landed, I docked my instruments in the lateral aspect of the superior articular process. Then I feel the superior articular process, so I get oriented with my intraoperative fluoroscopic images. After that, I introduce my endoscope but I continue touching my superior articular process, the lateral surface with my bevel. Then I rotate my bevel down, and finally I can start my procedure. Here is the SIP, the L5 SIP, the lateral surface. I am coagulating all the vessels, and I starting with the drilling. You can observe that the cancellous bone can bleeding, and this is a big issue when you are performing keyholes approach to the endoscope. For example, transpedicular approaches or rigid approaches, translaminar approaches. So after that, you can reach the most ventral part of the SIP by drilling. And the goal is to reach the foraminal ligament, the ligamentum flavum, step by step. You can see the epidural fat, and I coagulate before continue my procedure of decompression. Finally, I continue coagulate, and you can see the exciting nerve, L4, decompressed, and the traversing nerve, the L5 traversing nerve, decompressed. I use my probe to check if I accomplish a good decompression during my procedure. And finally, this is the postoperative outcome, radiological outcomes. You can see the foraminal stenosis, the nerve in the upper part of the foramen. I just cut or remove the tip of the SIP. And here is the axial view. I just cut the tip of the SIP and the degenerative changes of the facet joint.
And Javier, another quick question. Those were really nice videos, by the way. They're great videos, very, very informative and easy to understand. My question is, do you do all of these procedures under general anesthesia? Do you do any, or have you attempted any awake? What's your protocol for that?
Yeah, sure. This is a very common and important question. Transforaminal endoscopy can be performed under local anesthesia and conscious sedation. So the anesthesiologists are very important. They have to experience with these procedures, experience with the patient to avoid pain during your procedure and the mobilization, conscious mobilization of the patient during the surgery. So I perform always these procedures with local anesthesia and conscious sedation. The anesthesiologist use propofol or fentanyl, and she are always checking the patient. If I need that the patient moves the leg or moves something because a critical issue during surgery or a critical step, the patient can do that. But I use that kind of anesthesia. I never, in my first cases as a young spine surgeon and inexperienced endoscopic surgeon, also used intraoperative neuromonitoring, but the best monitoring is your patient. So your patient told you if he feels or it feels pain or anything else. Yeah.
There you go. That's great. That's really nice, and I think that just makes it so much easier for the patient as well. A couple, if you don't mind, I know you have a few additional excellent cases, but if I don't ask now, I'm going to forget. So a couple of things. So I noticed here, and this is just one cut, so it's not fair to make a, you know, a full evaluation based on that. But on the bottom right picture, where the green arrow is on the post-op L4-5, you know, to me, it looks like that's a lot of facet that's resected. Maybe it's in reality, it's not like that. But the question is have you encountered a case in which you perhaps drilled too much facet, too much joint, and you created instability? or is that not really an issue? And it's, I mean, it happens with the open technique, of course. So I imagine it can happen in endoscopy, but does it happen? And if so, are you able to recognize it there and then, or with post-operative images or clinical scenarios as otherwise expected?
Yeah, ventral facetectomy or trans-SIP approach only wants to reach the upper part of the SIP. I didn't have cases of iatrogenic instability for endoscopic spinal procedures. Maybe I believe that you can protect the capsule of the facet joint. You are working in the not articular part of the facet joint because it's too ventral. But I didn't see. In the next case, I will show you patients with previous grade 1 spondylolisthesis, fixed spondylolisthesis, then after procedure, after 2 years or 3 years, the patient is still without progress of the spondy. So I think that maybe I have to show more slides of this MRI, but no, I didn't have these cases of instability.
Okay, thank you.
Okay, let's go for the case 3, interlaminar endoscopic discectomy for migrated discs. It's about a 56-year-old female with pain radiated down her right leg, past 7, 6 weeks on evolution and no lower back pain. The neurologic examination demonstrates loss of the strength in dorsiflexion of the right ankle, numbness in the right leg, and hypoesthesia in the lateral aspect of the calf and dorsal surface of the foot of the right side. Right Achillean reflex abolished. Here is the preoperative MRI. The sagittal view, I marked in red the lamina, the L5 lamina and the S1 lamina, and the green arrow points to the upgrade migrated disc herniation. You can see the migration in the foraminal area in the sagittal, in the axial view. And the most important thing is you can observe in the coronal view of the MRI that your pathology is located in the axilla area between the exiting nerve L5 and the traversing nerve S1. So you have a very good and suitable interlaminar window for this approach. You can opt for go open or tubular, or also take into account another techniques, for example, translaminar endoscopic approach. But you have to remember that anatomically the lamina is not wider compared with other laminas at L5 and is too oblique. So with the translaminar approach, you can damage the parts, you can over decompress. Ipsilateral transpedicular approach, you have see the size of this pedicle, so you need for at least 8 millimeters of a keyhole, so you can damage the pedicle. And also the bleeding of the cancellous bone is important, and you cannot mobilize or lever-in your endoscope. And the thing is, you have to reach the target in the axillar area of this level. The transforaminal endoscopic discectomy can be a good solution for this kind of discernation at L45 or upper levels, but you can take into account the highest point of the iliac crest. I went for the interlaminar endoscopic lumbar discectomy in this case. You can see in the intraoperative C-arm views, the endoscope.
Javier,
please.
Sorry, I don't mean to interrupt. Just real question again before we get beyond it. One of our participants is asking, is it difficult or how hard is it to advance the cannula through the intertransverse ligament?
But you don't need to advance your cannula in the intertransverse ligament, because below the intertransverse ligament is the retroperitoneal area, so it's not possible. The transfer process and transfer process, the intertransverse ligament and intertransverse muscles, and the stabilizers muscles are a barrier against go through the retroperitoneal approach.
Let me ask you this: do you have to advance? Do you have to advance any cannula or any instruments through the ligaments? And if so, which ones are there besides, obviously ligamentum flavum?
Okay. In this approach, for example, you can put your dilators into the interlaminar window. Then you advance your working cannula, and you have different options. For example, you can remove partially the ipsilateral ligamentum flavum. But if you have experience and if you have a wider interlaminar window, like in this case, you can split the ligamentum flavum with your dissector and then go rotate your working cannula to reach the epidural space. First, the dorsal epidural space, and then the lateral and ventral epidural space, as we're gonna check in the video. So this is my answer regarding that question. Yes, here in the intraoperative CRM views, you can see that we are talking about that. We are in the interlaminar space, and we are working in the interlaminar space, but we reach the foraminal area through this approach. This is the intraoperative video. As I told you, this is my working cannula. So I advance through the ligamentum flavum and the S1 traversing nerve. You can see again here, this is the traversing S1 nerve. So I advanced my working cannula. My bevel is protecting my traversing nerve, but I'm in an oblique fashion, in an oblique trajectory to reach the foramen. So here is the exiting nerve. This is L5. In the depth is L5. And here is the space, the axillary space, completely free from the pathology. So this is the postoperative MRI. You can observe that the ligamentum flavum was preserved. It's not removed, just splitted during my surgery. And the foramen is free from the pathology in immediately postoperative MRI. The case 4 is about an interlaminar endoscopic approach for a juxtafacet cyst. It's about a 79-year-old female with pain radiated down her right leg, reaching the ankle and great toe, numbness and intermittent tingling in the right leg, VAS 7 for leg pain, but VAS 5 for back pain. Lower back pain is unilateral and coincides with the site of the cyst. 6 months on evolution, but sensitive disturbance is 5 weeks ago. You can see grade 1 spondy at L4, L5. You can see the pathology here, cyst, and degenerative changes in this level, causing also lumbar spine stenosis, central stenosis. So my treatment options offered to the patient was fused, but I believe in this case the lower back pain are caused by inflammation in the facet joint because of the cyst. Direct decompression, open miss. I went for ipsilateral full endoscopic interlaminar cyst removal. It was my procedure. You can observe that with the endoscope, you can navigate the dorsal epidural space through an interlaminar approach. Caudally, you can follow the traversing nerve. You can see or touch the exiting nerve. You can navigate dorsally the epidural space cranially, caudally, and cranially. And here's the video. The first thing is to recognize landmark. Here's the upper lamina. So you have to perform bone decompression and then observe the ligamentum flavum. In this case, you have to remove the ligamentum flavum, so you have to reach the cranial and inferior attachment of ligamentum flavum. You perform the same procedure that is performed as a tube, respecting an over-the-top technique, and until reach the attachment of ligament to flavum. And finally, you can perform the flavectomy, and you can reach the area of the cyst. Here is the material of the cyst. And you can conclude your flavectomy, removing the cyst. You have to conclude the flavectomy carefully because sometimes in chronic illness, the meningovertebral ligaments or adhesions between dura and flavum can be tight, and you can occur a dural tear that converts all the procedure. This is the contralateral decompression. You can observe the SIP impinge the traversing nerve. So we're remodeling just the SIP. We never could completely the SIP. This is inferior articular process. And we're gonna observe how we release the traversing nerve in the contralateral side also. And finally, we can observe in a panoramic view the complete ipsilateral and contralateral decompression and cyst removal. Here is the postoperative MRI, immediately postoperative MRI. You can observe the enlargement on the dural sac after the procedure, and you can see how we remove the cyst. And this is the 2 years postoperative MRI of the same patient. You can see that the spondygrade 1 never progress with the time, but obviously it's about an elderly patient with low physical activity, no? So any questions about this case, dear Ali?
Yeah, those are really excellent cases and very, very nice descriptions. And again, I want to remind our participants that you're welcome to ask, obviously, pose any questions for our speaker through the chat box, and I'll do my best to relay those questions. So I'm sure we'll have a few of them coming your way. I was going to ask you a question later, Javier, but maybe this is a good break to introduce this topic, which comes up often when it comes to technology, new techniques, which is the cost associated with these platforms. And depending on what region you're in or what country, sometimes it's harder to get those in. So can you tell us a little bit about your experience in terms of how to convince your hospital or your medical center to either lease or purchase this technology? And I know obviously things where you are different where I am and different where other people are, but just tell me a little bit about cost and bringing this technology into your hospital, and what's the mechanism that you use to convince the administration to invest in it?
Yeah, never asked that. So congratulations, dear Salih, because never asked this point, and it's very important. Right now, for example, here in Mexico, spinal endoscopy is expensive. Uniportal spinal endoscopy is expensive because my country has a different social health insurance than United States. So in Mexico, most of the people needs to pay directly the materials used in the surgery. So the costs are so highly. So we have to talk with the brands, the local brands that they have inverted buying endoscopic systems for a rent, for a reasonable rent for the people. So the hospitals never here buy the instruments like endoscopes. The patients needs to rent the endoscope. So in that sense, the rent for a procedure decreased with the use of the endoscope by a surgeon. So the local brands, the local industry said, okay, if you perform endoscopic procedures, you can reach better prices. But if you are performing just one procedure by month, no, the costs are more expensive. So that's the reason that I have introduced in my country biportal endoscopy, because biportal endoscopy is performing through an arthroscope, and all the hospital has they have arthroscopes in the surgical tools in their armamentarium, because orthopedics use them a lot of things and a lot of times for arthroscope. So in the next case, I will show you the biportal technique to reduce cost regarding endoscopic procedures. This is the case 5, interlaminar endoscopic ULVD plus sequestrectomy. This is this case is about a 73-year-old male with severe electric shock pain radiated down his left leg, past 9, no lower back pain, 4 weeks on evolution. Opioids treatment can improve right now the symptoms. The clinical examination demonstrates decrease of strength in the left ankle dorsiflexion, claudication of the left leg because of pain, left patellar and Achillean reflexes abolished. The preoperative X-rays demonstrate a spondygrade 1 fixed in this patient. So this is the preoperative MRI. Because of the age, degenerative changes, hypertrophy of the flavum, hypertrophy of the facet joints because the spondy maybe, and also we can observe this herniation in the ventral epidural space at the level of the disc and a little bit upward migration. We have to talk with the patient, give options for this pathology. Maybe this pathology can progress with the time, but patients decide with you and with the knowledge what is the best solution for them. And the patient didn't accept the fusion, so I went for an interlaminar full endoscopic ULVD plus sequestrectomy. I used a bigger endoscope. In this case, is called Stenoscope. It's a 10 millimeters endoscope, Ilesis Delta from Joymax brand. And here, these pictures can demonstrate how we perform the ULVD procedure through the endoscope. We decompress first the ipsilateral side, then we cross the midline through decompression or bone removal of the base of the spinous process to cross the midline and get access to the contralateral side, and then conclude the procedures in a more oblique trajectory. Here is the intraoperative video. We use in this case this side cutting burr. We are performing the partial laminotomy, and we drill more medially the base of the spinous process to cross the midline until reach the attachment of the ligamentum flavum. And then here is the contralateral side, and we perform the flavectomy piece by piece, again, carefully, because the adhesions between dura and flavum. When we can observe free the nerves, I went for the ventral epidural pathology. So the discernation was there. So we removed the discernation. And finally, you can observe a complete decompression of the neural elements, the traversing nerves. And you can see also in this picture how we cross the midline with the uniportal endoscopic technique. You can see the postoperative MRI, immediately postoperative MRI, good decompression was achieved through this approach. You can see here the drain that I left in postoperative status for at least 6 hours or 12 hours. And this is the comparative X-rays, the comparative X-rays with a grade 1 spondy, and the 3 years postoperative follow-up X-ray demonstrate no progress of the spondy. The case 6 is about UBE, is unilateral biportal endoscopy for multifocal stenosis. I perform a contralateral sublaminar approach for ULVD. Unilateral biportal endoscopy is known as biportal endoscopic surgery or dual portal surgery. The main difference in this technique is a water-based endoscopy, but you are working in a different channel for your working tools compared with uniportal. In uniportal, you have to introduce the surgical tools through the endoscope. In this technique, you have certain degree of freedom by using your surgical tools. So this technique depends on a correct and proper triangulation of both portals. One portal is for the endoscope, another portal is for your surgical tools. And the basics is create a space and a circuit for a proper inflow and outflow of the saline. You can observe. In the paramedian approach, you are working medially to the multifidus triangle, where it's filled with loose connective tissue, fat tissue. So the bone landmark for the paramedian, posterior paramedian approach is a very familiar and common landmark for all the spine surgeons that perform posterior approaches. Is the spinous process and lamina, so the spinolaminar junction is the bone landmark to dock your instruments, and then you can reach the interlaminar space. In these images, you can see how we reach the contralateral side through the biportal endoscopic approach. It's very easy because you have freedom movements with your hand with what you are working. So this case is about a 67-year-old man with Parkinson's disease, a chronic consumption of opiates because of pain in the right leg, history of spine surgery 8 years ago, and interspinous device at L5S1. The chief complaint was severe radicular pain in the right leg, treated with foraminal block also at L4L5 and L5S1 with no improvement. 7 months on evolution, but more severe 6 weeks ago. VAS9, numbness and paresthesias in the dorsal surface of the right leg. This is the clinical examination. We can think that this is a common Parkinson gait, but now the patient has a lot of pain in the right leg, and you can observe the decrease of the strength in the right-sided ankle dorsiflexion. So these are the preparative X-rays. No special issue. You have degenerative changes in a Parkinson patient, osteophyte, anterior osteophyte, marginal osteophyte, decrease of the intervertebral, this height in regional lumbar spine. But in the MRI, you can see the central severe central spinal stenosis with osteophytes in the attachment of the ligamentum flavum and a severe lumbar foraminal stenosis at L4, L5 in the right side. So this is the preparative CT scan. You can see the calcification of the insertion of ligamentum flavum and also degenerative changes, some ex-vacuum phenomenon in the intervertebral disc space in regional in the spine, but the patient never complains of lower back pain. So we conclude a diagnosis of symptomatic L4, L5 lumbar spinal stenosis, central and foraminal in the right side. We talked in fusion, in direct decompression, and in minimal invasive procedure for direct decompression. So I decided to procedure of biportal endoscopy, ULBD, and contralateral sublaminar foraminal decompression at L4, L5 on the right side. This is the view through the biportal endoscopy. You can see the L4, the inferior edge of L4 lamina in the right side. So we perform the laminotomy until reach the attachment of ligamentum flavum, completely similar to the uniportal techniques. After that, we cross the midline by drilling the base of the spinous process in a laminar approach. We use key-cells and other common surgical tools to remove the osteophytes in an over-the-top technique, with that over-the-top technique to preserve and avoid damage of the neural elements. We have been very careful with the neural elements regarding the flavectomy, especially in patients with chronic illness because of these additions. And you can observe the central decompression, good central decompression, and the additions between the ligamentum flavum and the thecal sac. Then we perform the medial foraminotomy through the interlaminar space. You can see the exiting L4 nerve here after remove the tip of the superior articular process. So I told you before, we never remove all the superior articular process. This is the ventral aspect of the superior articular process. I remove the tip. Here's the inferior articular process. Here's the exiting nerve, and good decompression was achieved through this technique. Here is the comparative images. Here's the preoperative MRI. This is the trajectory of our approach, similar than seen in the tubular surgery. We remove only the tip of the superior articular process. We decompress centrally very well the central canal, and this is the postoperative clinical status of the patient 1 day after surgery, before being discharged from the hospital. And this is the 9-month follow-up of the patient. So the gait is not completely of Parkinson disease. The gait improves, the pain improves, as usually after a direct decompression of the neural elements.
Javier, if I can interrupt for a second, I mean, these are outstanding cases. We have a question. We have a couple good questions. So the first one is, I think you're obviously impressing a lot of our participants. So one question is, how many cases do you think you've done endoscopically? What's the total number of cases that you have, as they say here, under your belt?
Okay, maybe since 2018, maybe we are in the 375 case, endoscopical case, since 2018. But I think that my learning curve was shorter because I performed first spinal surgery, then I performed minimal invasive spinal surgery with tubes and all the kind of techniques. And finally, I performed 1 year, especially in endoscopy. So I have seen some young surgeons that want to jump from neurosurgery or orthopedics to endoscopic spinal surgery. It's good because each human has different skills, and but I think it's very difficult because you have to have background to perform any kind of procedures. And the first person is the most important in your making decision is your patient. So this is the reason that you have to be prepared with any technique that requires your patient, not only endoscopic procedures. So yeah, I have a few cases compared with Asian doctors or American colleagues.
Yeah, no, those are excellent numbers. So let me just make sure I have the math right, because this is important for a lot of us here who are listening. So so you're doing approximately 10 cases a month?
Yeah, maybe
10 cases a month.
Yeah, 8, 10, sometimes 13 cases of endoscopic procedures. But my practice, as before the talk told you, is not only for endoscopic procedures. We perform all kind of spinal surgery. Yeah.
And the other question that's kind of related to this is, and I apologize if you're going to get to it in your follow-up cases. I don't know if we have time for more cases because this interaction is very important. But can you share with us what? Well, I have two questions. Number one is, do you keep any clinical? Do you have a clinical outcomes database, or do you use any metrics to objectively analyze how your patients are doing post-operatively?
Yeah, it's that scientific methodology is the most important thing to judge.
I told you we're going to ask hard questions. We videos, but now we're going to talk about two things: about how you objectively measure performance of patients after endoscopy, and then the second question, just to prepare you, is to talk to us about your complication profile and what type and what nature of complications you see in your practice.
Yeah, I follow up my patients with all my colleagues. I have fortune. I'm lucky because my colleagues are my dad. My dad is neurosurgeon, spinal neurosurgeon, and my brother is a spinal neurosurgeon. So we work together as a family and as a colleague. So we have a research department with our students. So we follow up with scales, OD, BAS, NSA, all for patients with cervical or thoracic diseases. So we follow our patients. After discharge, the patient comes with us 12 days after surgery, then after, the first month after surgery, then 3, 6, 9, 12, and 24 months after surgery. So I don't have long-term follow-ups because this is my third year after my subspecialty working, but my outcomes are good compared with different small series in publishing. The other question is my complications profile. Yeah, I have seen complications in my cases. Thanks God, complications that I had are not severe, but yes, and it looks similar to the published in the literature. The first one is dural tears. Okay, dural tears is not maybe 3 or 4 times in my series. I had a dural tear, and it was resolved with sealant, sealant, and the one case I have to convert the surgery with that tube. In fact, my brother told me, shared that case with in this lecture. So I had the dural tear. I see the nerve roots. So I stopped the surgery. I convert the surgery. I put the tube and put stitches and sealant, and that's all. And the patients went good for good outcome. So yeah, dural tears are the first one. The second one is sometimes postoperative radiculitis. Postoperative radiculitis, especially in transforaminal approach, and delayed radiculitis I have seen that kind of complication. I never have seen in my practice infections. I never have seen postoperative iatrogenic instability or damage of the nerves, because as you see, I am so careful with my things and with my method. So these are my main complications.
Wonderful. Thank you for that. And you know, I'm not going to ask you here. I'll ask you over WhatsApp later whether your dad gives you a hard time about doing these cases, and probably just says, "Oh, why are you wasting your time with this? Just do the open surgery." But
no.
You don't need to answer that. One final question for the audience. Obviously, this was an excellent lecture. By the way, as I told you, and as our participants know, in a few days, this will be up on YouTube, and we'll be able to hopefully look at those videos again in excellent cases. Last question, and I apologize, I didn't mention this in the introduction, but your fellowship training in endoscopy in Seoul, South Korea was with which hospital? What's the name of the hospital?
Yeah, I was lucky because Professor Jun Sung Kim was my mentor. It was my brother's mentor also. So we are undergraduate of Seoul St. Mary's Hospital from Catholic University of Korea. So it was my school for minimally invasive and endoscopic procedures.
I understand. Yeah. Oh yeah, I mean, he's a great surgeon. I mean, I follow a lot of his work online, and you're right, he's one of the pioneers in endoscopy there in that part of the world and outside. We're coming here to the end. Javier, thank you so much for doing this. It's you know, I feel that every year, every time we get better at this, and certainly for the ones that don't do endoscopy like me, I learn a little bit more about it. And certainly that at least now the videos and pictures make sense to me. I would say 5 years ago, I could just, you can show me that video 20 times, I wouldn't know what's what. But this was absolutely great. We have a lot of participants here from really all over the world and in different phases of their training and practice. So thank you for joining us, and for the rest of the group here, we'll meet again next Thursday, same time. It'll be our last session of 2021 because we will be off for the holiday season. So we'll see everybody next week. Thank you, Javier. Thank you to the participants, and have a great evening, everyone.
Thank you so much. See you.